Typically, the young people in the home are what would be called severely ill, i.e. they've been in hospital, often with multiple episodes of self-harm, self-injurious behaviour, sometimes at a very significant level, sort of suicidal, and difficulty forming relationships, not able to access therapy because they're too disturbed to access therapy, and also often on a combination of relatively high dose medication. Over the time that they're in the house, the timescale is important actually, so the timescale is quite long, so you might be talking over 6 months to 12 months. One would hope that you could first and foremost reduce the amount of medication needed, ensure that they can form relationships, day-to-day relationships with the staff, which is the bedrock of the therapy, and then have additional therapeutic relationships with specific therapists for CBT, DBT, cognitive behavioural therapy, dialectical behavioural therapy, etc. The outcome of that is a reduction in symptoms, a reduction in the amount of self-harm. For these young people, you have to be mindful of the outcome. So it's unrealistic to expect somebody to go from severely ill, needing hospital care, to everything's fine, no problem. So you tend to think in terms of, have we reduced those symptoms? Are they going to casualty A&E every day, or is it every week, or is it a rare event? And I think the other important measure of change, thinking about the young people we've got now, is, are they accessing education? Are they managing to go to school? So, for example, at the moment, the older ones doing their GCSEs, worrying about whether they've got the answers right about photosynthesis or something. Well, that's a much more normal worry than everything else. One of the other young person applied for a job, got an interview tomorrow. Now it'll be part-time work, but that change from where they were to where they are now is phenomenal.